logging in and listening today. I'm going to chat about asthma and food allergies, particularly in the school setting, and how you can set your child up for success this year and every year to come. One of the most important things that I always talk about with families in my clinic who have children with allergic diseases is surrounding preparation and clear communication. These are going to be the major themes when getting ready for back to school. I'm also going to touch a bit on a topic that's not fun to discuss, but very important for all school-age children, whether they have allergic diseases or not, and that's bullying. Finally, it's a topic I've been asked about a lot over the last 4 to 5 months, so I'm going to wrap up with a few lines about COVID and what we currently know. Let's start with asthma. When thinking about communication, one of the most important things your child should have at school with them, and it should be updated every year, is a written asthma action plan. Have you seen these before? I'm going to share one in just a second, but this form helps to communicate with the school nurse, teacher, and other school administrators about your child's condition. So this is the standard Colorado school action plan for asthma. As you can see at the very top of the form, it has your child's demographics, the name, the school, what grade they're going to be in, what their known triggers might be, and if they have any other allergies. This would be relevant especially for foods. Then it goes down into the plan. So there's 3 different zones, like a stoplight: the green zone, the yellow zone, and the red zone. Green zone is we are feeling pretty good. We're feeling asymptomatic, going about our lives, day-to-day activities are normal, but we're treating ourselves at home with our controller medications. And you can see there's a spot right here where we list those which your child may or may not be using at home on a daily basis. And then their quick relief medications in case they start to have symptoms in the yellow or red zone. This is where their quick relief medication would be listed. So the yellow and the red zones go through some of the symptoms that your child might experience and what medications and how much medication to give. These forms are helpful to keep at school because it is a written plan. It shows exactly what you should be doing for which symptoms, and it's helpful for other caregivers who might not be your child's primary caregiver in case there's any emergency. So again, this form will be kept on file, and if any issues arise at school, this plan is in place so that your child receives the proper treatment. I encourage children not to be ashamed or afraid to let their friends know about their condition also. Their friends can be helpful if any symptoms arise at school and help get help if needed, but also be allies should bullying occur, and we'll touch on this a bit more. Regarding preparation, it's best to start before the school year begins. If it's been a while since your child's last checkup with their asthma doctor, this is a great time to touch base to ensure you have medications and all of the forms necessary for the start of the school year. Some children have asthma that is treated year-round, while others treat more seasonally through the fall and winter months. And some children have intermittent asthma where they may only have a rescue inhaler. If your child treats seasonally, ensure that they have started their fall and winter controller medications before the start of the school year. Every year, we see a September asthma peak. The 3rd week in September has historically been the peak week for asthma flares, emergency department visits, and hospitalizations for asthma. 25% of all asthma hospitalizations happen in September. And if we're looking at the school year on the whole, there are 10.5 million school days missed every single year due to asthma. So why does the September peak happen? Well, it's multifactorial and a perfect storm of events. The back to school time of year brings with it new pollen seasons, high levels of ragweed and molds, new indoor environments that might have new allergens or irritants that have been avoided all summer by being out of the classroom, increased levels of stress and anxiety with going back to school, and germs start to circulate, including those easy to catch cold viruses and flu. And this year we also have COVID. Preparation can help prevent your child from suffering this September. Asthma can be challenging because asthma symptoms can arise suddenly and require rapid treatment. Despite our best efforts, we may not be able to prevent all potential triggers. Every child with asthma should have an albuterol inhaler at school with instructions for use. This goes right along with their plan. I also recommend that they use their inhalers with a spacer no matter how old they are, and keep an extra spacer at school. If you're not familiar with a spacer, it's essentially a clear plastic tube that has a valve and a place where you put the inhaler and a place where you have where you inhale for the mouthpiece. And so this is used to help distribute the medication and for ease of use. And like I said, no matter what the age, I recommend that children use a spacer. Proper technique is also key. If your medication and spacer aren't being used properly, your child may not be getting any benefit at all from the medication if they're not receiving it into their lungs. It's recommended that a school nurse monitor use when using an inhaler and a spacer to ensure that your child is receiving his or her medication appropriately. Knowing your child's school environment can also be helpful in identifying potential triggers and how to best avoid them. Animal dander, chalk dust, mold, these can all be irritating and trigger asthma attacks. Exercise at recess or with after-school sports can trigger exercise or pollen-induced symptoms, especially when they're exercising outside. With the back-to-school time being in the late summer and early fall, we're transitioning between allergen seasons, with grass pollens starting to diminish, but weed pollens rising. If these potential triggers can be identified and avoided as best as possible, or in the case of exercise, using a pre-treatment medication such as albuterol before exercise if your child requires that, your child will be at a lower risk of having an acute asthma attack. And to help with those pesky viruses, and not only this year with the current pandemic, but you can always encourage your child to wash their hands frequently to help reduce the risk of catching a cold. This year, more than ever, mask wearing will also be helpful in reducing the risk of catching other illnesses and not just COVID. So moving on to food allergy, preparation and communication are again key. Up to 8% of all school-age children in the United States have food allergies, which is about 1 in 13 children, or potentially 2 children in every classroom. And schools have been adapting and learning about this condition over time. When thinking about the upcoming school year, it's important to know what are the policies surrounding food allergy at your school or within your school district. Policies can be highly variable between schools, even in the same city. Examples of some of these policies include knowing if your school allows epinephrine auto-injectors to be in the classroom or in the child's backpack, or do they need to be in the nurse's office or with a teacher? Are there food allergy-free tables or classroom at your child's school? And how do you and your child feel about them? What is your current understanding about food allergies? And what is the school's current understanding of food allergies and education surrounding allergen avoidance and the treatment of allergic reactions in your school? With you and your child and your understanding of his or her food allergy, would it be worth a checkup with your allergy doctor to discuss, or are there any new concerns prior to embarking on the new school year? These are all questions that are important to address on a yearly basis to be as prepared as possible in preventing and treating a food allergy reaction at school. Similar as in children with asthma, there should be communication with your child's teacher, school nurses, and school administrators to let them know that your child has a food allergy and which foods are being strictly avoided and which foods are safe. Every food allergic child should have an anaphylaxis action plan on file at school, and this should be updated on a yearly basis. Let me pull up an example. This is the standard Colorado Allergy and Anaphylaxis Action Plan or Emergency Care Plan. So again, similar to those asthma plans, it's going to have your child's demographics and what they are allergic to. There might be additional history as to what their reactions may look like. And of course, if they have any other allergic diseases, especially asthma. The scoring system here, or the symptoms rather, show what a mild symptom would be and what a severe symptom would be. And this gives instructions on what medication to use in the event of a reaction. So for mild symptoms, we typically start with an antihistamine. And then for severe symptoms, epinephrine is always going to be the first drug of choice. And it should be used as quickly as possible if there is concern for a severe allergic reaction. These forms should be filled out by your physician and signed by your physician, and also have instructions on how to use the epinephrine auto-injectors. So as I mentioned, the plan should be kept at school on file and be updated every year. Along with the plan, emergency medications should be up to date and kept at school for the year. There should be an oral antihistamine for those mild reactions and injectable epinephrine for severe allergic reactions. I typically recommend to my patients that they use liquid cetirizine, which is generic Zyrtec, instead of Benadryl for any mild reactions. Benadryl's been around for a really long time, but we have newer and better drugs now. Cetirizine starts to work as fast, if not slightly faster than Benadryl. It lasts longer for about 24 hours versus a little over 6 with Benadryl, and it is not as sedating as Benadryl. An epinephrine autoinjector 2-pack should also be at school with your child. There are several different brand names and generic names now with the epinephrine autoinjectors, but they all come in a 2-pack, and both devices should be kept together and sent to school with your child. I have one of the AviQ trainers here with me today, but this is just one of the options for injectable epinephrine that your child can have at school. One of the nice things about the AviQ is that they talk to you when you use them. And so for folks who may not be as familiar with the epinephrine autoinjectors, they may be easier to use. If your child is able to self-carry his or her epinephrine device, back to school time is a great time for a refresher on how to use their specific device to ensure that they're comfortable using it should the need arise. I also encourage your child's close friends and their family members to be trained on how to use the epinephrine injectors should the need arise. Epinephrine autoinjectors come with these training devices that I just showed you, and this can be used not only for the family and the child to refresh on their proper use, but you can also use it to instruct anyone else who may be caring for your child with sports, with after school care, or at school itself. Outside of the standard anaphylaxis action plan, some children also have a 504 plan. Not every food allergic child will need this plan, but if it is something that you feel your child needs, you can work with your doctor on this. Another way to prepare for the school year is to know your child's environment and how this may change throughout the school day and throughout the school year. For example, knowing the cafeteria and policies there, you should consider whether you'll be providing your child with homemade meals and snacks versus school-made meals and snacks, and communicating with staff who will be preparing this food and finding safe options. There may also be after-school care, field trips, and other special events throughout the school year, which will bring with them different circumstances surrounding the food your child may be exposed to. These changes throughout the day or year may require a bit more planning, but the advanced planning will help keep your child safe. And this may be old news if you have older food allergic children, but a recommendation that I always make for school and at home is to start communicating with your child at a young age regarding their food allergies. They should know that they have safe foods and unsafe foods, and that unsafe foods can make them very sick. They should learn that they should only accept foods given to them by a trusted adult, such as their parents or teachers, other family members or caretakers who know about their allergies. Finally, they should know that they should find an adult should they feel sick and think they need help. For older children, especially teens and into the young adult years, it's critical to keep the lines of communication open and that they continue to carry their epinephrine autoinjectors. Older kids and young adults and those with asthma are at the highest risk demographics for having severe, life-threatening, or even fatal food reactions. Older kids may not want to carry their epinephrine, and I always tell kids in my clinic, this AviQ is smaller than your phone, so there's no excuse for not carrying it. They may start to engage in risk-taking behaviors or deny their condition. If you have kids who are heading away to college, your child should be very mindful of the consequences of alcohol ingestion on food allergy reactions. Alcohol can lower your reaction threshold to any food and inhibit judgment, leading to potentially risky behaviors around food. As children get older and more autonomous, your allergist can help navigate you and your child through their changing needs. Moving on to a topic that is not fun to talk about, which is asthma, food allergies, and bullying. As I've mentioned above, asthma and food allergies in school-age children are very common. Unfortunately, children with food allergies and asthma are often targets of bullying. Some children with asthma are embarrassed by their need for medications on a daily or intermittent basis to treat their symptoms, while children with food allergies have food restrictions, and the need to have epinephrine and antihistamine readily available. For these reasons, children with asthma and food allergies may have decreased participation in school activities or sports, and several studies in children with food allergies and asthma have demonstrated that kids are at risk for social isolation and increased school disruption in their day, which can lead to increased bullying. About half of kids who are being bullied do not tell their parents. Bullying in children with allergies and food asthma can be physically dangerous. For example, if children are scared to take their asthma medications in front of other kids or outside of the home, they may be prone to more asthma attacks. Kids with food allergies can be physically bullied by having the food that they're allergic to put in their face or being forced to ingest the food, which can lead to a severe reaction. So, what can we do? Parents, friends, families can all help. Encourage open communication between your child and yourself and other trusted adults. Teach kids to stand up to bullies by teaching them to say no, stop that, or I don't like that in a confident voice and walking away. Watch for signs of bullying: torn or damaged clothing, torn backpacks, damaged backpacks or books, increased avoidance of school, fear of school, nightmares, headaches, and stomach aches can all be signs of bullying. Unexpected asthma exacerbations or food allergy reactions at school may also be signs of bullying. If a child is being bullied that you know, ensure them that you will help. Don't confront the child or the child's parents who are doing the bullying, but go to a trusted adult at the school. A school nurse, a counselor, or other trusted individual may be able to start educational programs at the school surrounding bullying in the setting of a chronic illness or of the illness itself. I always tell my school-age patients not to be afraid to let their friends know about the condition. They can help in case of an emergency, but also a trusted friend or group of trusted friends can be helpful when children are in vulnerable situations, such as in the lunchroom or on the school bus. Finally, I wanted to touch briefly on COVID, or the coronavirus 19 virus, especially in the context of asthma. With our rapidly changing understanding of COVID-19, you may have heard variable reports about risk factors for having a severe disease course if you were to contract COVID. Currently, there's no evidence to suggest that patients with asthma are at a higher risk of contracting COVID. Essentially, any exposed individual, whether you have an underlying health condition or not, is at risk of contracting COVID-19. With our current available literature, there does not appear to be a significantly increased risk of morbidity or mortality from COVID-19 in asthmatic patients. The highest risk conditions for having a severe disease course are obesity, chronic kidney disease, diabetes, cancer, heart conditions, sickle cell disease, COPD, which is chronic obstructive pulmonary disease, or those with immunocompromised states. Keep in mind that though many asthmatics do suffer from asthma flares when they get a respiratory illness, and this is no different with COVID, they could still have a severe flare of their asthma. When it comes to treating asthma during the pandemic, I have been advising all of my patients to really be aware of their symptoms and ensure that they are taking all of their medications as prescribed to keep their lungs in tip-top shape. Inhaled steroids used in the treatment of asthma are safe and necessary for patients with asthma to continue to use in order to prevent exacerbations. If an asthmatic patient does develop an asthma exacerbation due to COVID, other illnesses, or any other triggers, oral steroids may still be needed for the treatment of their acute asthma flare, and we would treat accordingly pending the severity of their symptoms, as we typically would COVID or no COVID. We also know that wearing a face covering can help protect everyone around you, and there is no contraindication to wearing a mask if you have asthma or allergies. In fact, if you do suffer from seasonal allergies, a face mask may reduce your exposure to your allergens. Face coverings can also reduce your risk of catching other viruses that can flare asthma. So in summary, continue to treat your asthma and your allergies regularly, and maybe even a little more aggressively than you normally would this year. Stay on top of your symptoms and treat any new symptoms as soon as you notice them so that they do not worsen or become uncontrolled. I also strongly recommend that everyone get a flu shot this fall. And with that, I want to thank you for listening in, and I wish you a happy and healthy back to school time and fall.